Good evening, everyone, and welcome back, or welcome if this is your first time attending. This is the Canadian Concussion Center's webinar series, which is sponsored by LiUNA, which is a Labor's International Union of North America. My name is Leslie Rattan, and I'm really pleased to be moderating our webinar series that was developed for individuals with concussion, their family, and we also have healthcare providers attending as well. So if you've been with us before, the first half we run from 6 o'clock to 7. And about the first half, we have been having expert speakers who present on a particular topic. And then that is followed by a question and answer period. So if you look at the bottom of your screen, you'll see that there is both a chat button that you can click on. And if you have any technical difficulties, please just type your difficulty in there, and Christian will get back to you. There's also a Q&A. So if you have any questions for our speaker tonight, feel free just to enter those in there. Now, just before I go any further, we're going to just run a very quick poll. And this is just helpful for us so that we know who is attending. So I'll just give you a second to complete that. Great, thank you. So for this evening's session, I'm really pleased to introduce Dr. Neal Parekh, who has returned to join us to talk about traumatic brain injury and sleep. Dr. Parekh completed medical school at the University of Toronto in 2005. He completed his neurology residency at the University of Ottawa in 2010, followed by a sleep medicine fellowship at the University of Toronto in 2011. He holds certification as a sleep medicine expert through the European Sleep Research Society, and he's currently the medical director of the neurology program at Altum Health at the University Health Network, which is a program focused on assessing and treating head-injured workers. And with that, I'm going to turn it over to Dr. Parekh. I will just also let you know that Christian has posted in the chat a PDF of tonight's talk if you're interested in that. And with that, I'll turn it over to you.
Great. Thank you, Leslie. And thanks everyone for taking the time to attend this evening. And thanks to the hosts for inviting me to speak. So as you heard, today I'll be speaking about sleep issues in the TBI population with a real focus on the sleep problems that can occur post-concussion. Oh, and I'm struggling to change the slide already. Here we go. Let's try to figure this out. There we go. So from a neurology perspective, I don't have any disclosures. From a sleep medicine perspective, I have received an honorarium to sit on an advisory board for a sleep medication. I will not mention that medication specifically, nor will I endorse that medication, but the class of medications to which that medication belongs will be very briefly mentioned. So I'm hoping that at the end of today's session, the audience will have a basic understanding of sleep physiology, that the audience members will be able to identify sleep disorders in the TBI population more readily, and perhaps even formulate an initial treatment plan for common sleep disorders. How we define sleep is actually electrographically. I'm not going to walk through all the stages of sleep, but the two that I want to highlight are at the bottom. What used to be referred to as delta sleep is now called stage N3 sleep. And this is what is often referred to as slow wave sleep or deep sleep. It's the type of sleep that we think of as being restorative and refreshing. The other relevant sleep stage is what is now called stage R sleep, otherwise known as REM sleep. This is the state of sleep where most of our dreaming, or at least our most vivid dreaming, occurs. And in a typical night, we actually cycle through the various stages of sleep. And as you can see from the from the hypnogram on the screen, the initial parts of the night are spent predominantly in slow wave sleep or stage M3 sleep. And as we cycle, we spend a progressively longer period of time in REM sleep. The reason that is relevant is that sleep disorders that tend to manifest during stage M3 sleep tend to present earlier in the night, and sleep disorders that occur out of REM sleep tend to manifest later in the night. So sometimes when symptoms occur can indicate what the issue might be. So how do we sleep and how do we wake up? Well, there's really two main factors that regulate our sleep-wake cycle. The first is what we refer to as homeostasis or process S, and that's really just sleep debt. So the longer we're awake for, the more metabolic waste accumulates in our body. And a lot of these, what we think of as waste products, are actually somnogenic or sleep promoting. And so, if we think about our lives and, let's say, a day where we have to wake up particularly early or we have particularly bad sleep, it is often easier to then fall asleep that following night because we've been awake for a longer period of time. Or the flip, if we take a nap in the evening and pay off some of that sleep debt, it's of course going to be more difficult to fall asleep at night. And the other part of this regulation is our circadian rhythm, or process C. That's an internal clock that sits in our brain that tells us when it's time to go to sleep and when it's time to wake up. The sun or sunlight can strongly influence this, which is why sometimes our sleep patterns can change based on season or sun exposure. There's lots of theories as to why we sleep. I'm not going to go through this entire slide, but there's, when we talk about concussion, there are sort of a few theories about why some of the symptoms or persistent symptoms might arise. There's theories that talk about inflammation as part of the pathophysiology of concussion and post-concussion symptoms. And as you can see here on the slide, that there is some literature suggesting that chronic sleep restriction can be associated with low-grade inflammation. When we think about the cognitive symptoms associated with concussion, well, recognizing that REM sleep might help with memory consolidation becomes particularly relevant. So it's not surprising that sleep and concussion are relevant to each other. So when we talk about symptoms, sleep can interact or influence a lot of symptom domains. So when we sleep poorly, it can affect cognition. It's why we tell our children to get a good night's sleep before an exam. Poor sleep or sleep disorders can also lead to daytime fatigue. But some domain interactions are actually bidirectional. So, of course, if we're in pain, it can make it difficult to fall asleep, like if we have headaches or back pain. But similarly, there have been studies that have showed that sleep deprivation can actually lower seizure threshold. So, meaning, things that might be less painful actually feel more painful when we're sleep deprived. And similarly, certainly things like anxiety and depression can cause difficulty falling asleep, for example, but poor sleep can also worsen mood and worsen anxiety. So are sleep disorders common in the TBI population? Well, obviously the answer is yes, otherwise we wouldn't be here. But there was one study that's shown that approximately 50% of patients with traumatic brain injury actually had some type of sleep disturbance. And the study broke it down in terms of what kind of sleep disorders are seen, and they compared it to what is expected in the general population. So you can see that many sleep disorders are much more common post-traumatic brain injury. And the probably the most common is actually insomnia, which we'll spend quite a bit of time talking about. but 3 times more common in the TBI population. You can also see that nightmares are much more common following a head injury as well. And so is sleep apnea, which is a little bit harder to understand, but there are some theories about that we'll touch on shortly. So just a little bit of nomenclature before we move forward. So when we talk about insomnia as a symptom, it really just means difficulty sleeping when you want to be asleep. And hypersomnia is difficulty staying awake when one wants to be awake. The term hypersomnia really means sleeping too much, but it's often used interchangeably with excessive daytime sleepiness. And a parasomnia is an abnormal or unwanted behavior in sleep. So what the International Classification of Sleep Disorders has done is they've categorized essentially all of the sleep disorders into larger categories. And we will, through this presentation, walk through these different categories, highlighting the sleep disorders that are most relevant to the concussion population. So insomnia is probably the most frequently encountered symptom. And I just want to take a moment to sort of stress the idea of insomnia as a symptom as opposed to insomnia as a disease. So when we use the term insomnia, we really mean a symptom. So again, a difficulty falling asleep or difficulty staying asleep. That's what insomnia is. And it's much more common following a mild traumatic brain injury than actually it is when compared to those with a moderate or severe traumatic brain injury. In fact, so common that almost half of people who have suffered an MTBI have insomnia beyond 6 months from their injury. And this is different than chronic insomnia disorder. Chronic insomnia disorder, of course, has insomnia as its main symptom, and that can be difficulty falling asleep, staying asleep, waking up earlier than desired. But in order to be diagnosed with chronic insomnia disorder, that insomnia symptom has to lead to some kind of consequence. So that consequence could be fatigue, that consequence could be difficulties with attention or concentration, it could be mood issues, it could be daytime sleepiness. And if this symptom of insomnia is present and is causing a problem, and no alternative explanation can be found, then we call that chronic insomnia disorder, and that has a specific sort of treatment algorithm that we'll touch on shortly. The next category of sleep disorders is the sleep-related breathing disorders, and the most commonly seen sleep-related breathing disorder post-concussion is actually sleep apnea. So sleep apnea is a condition where our upper airway repeatedly narrows or collapses while we're sleeping, causing our oxygen to repeatedly drop and causing our sleep to become fragmented, whether we're aware of it or not. And it's a little bit unclear why it's so common in the post-concussion population. There are some theories. One thinking is, well, maybe people who have sleep apnea are actually more likely to injure their head. Perhaps they're more sleepy and more likely to get into a car crash, or maybe they're more inattentive and more likely to bump their head on a door frame. Another theory is that, well, if we're looking at patients who have not recovered in the typical, or what we used to think of as a typical time frame, well, maybe sleep apnea is actually protracting or preventing that usual recovery from happening, which is, wouldn't be unsurprising if, would be unsurprising for a brain that's deprived of oxygen at night, to recover more slowly compared to a brain that isn't deprived of oxygen. And then the other possible theory, I suppose, is that the sleep apnea is manifests or becomes worse following TBI because of sort of indirect factors. So that might be weight gain. So, after any kind of injury, we may become more inactive. We may change our eating habits, or maybe we're put on medications that cause weight gain. And there's a strong relation between sleep apnea and weight gain. Or maybe we're put on sedatives or muscle relaxants. Craniofacial trauma can distort our anatomy and also result in sleep apnea, though this is less common post-concussion. The other type of sleep breathing problem that's seen post-concussion is something called central sleep apnea. That's different than obstructive sleep apnea. With central sleep apnea, it's really a failure of the brain to initiate or trigger the breath. And opioids are probably the most common reason for that. And again, post-concussion, some individuals are put on opioids. So something to be aware of. The next category are the central disorders of hypersomnolence. I am not going to spend too much time on this, only because this is, I would say, fairly rarely seen post-concussion, with the exception of hypersomnia due to medications or substances. So that we do see fairly frequently. So that could be things like alcohol, and like pain medications, sedating, antidepressants, sleeping pills. All these substances can cause excessive sleepiness or excessive sleep. And then there's the circadian rhythm sleep-wake disorder. So as we spoke about earlier, one of the factors that helps us regulate our sleep time and our wake time is our circadian rhythm, that internal clock. And in some individuals, that internal clock can get disrupted. And there was actually a fairly recent, I guess we're going on maybe 3 years now, a Canadian study that identified that a quarter of patients who have suffered an MTBI and have insomnia actually have not chronic insomnia disorder, but insomnia due to a circadian rhythm sleep-wake disorder. And delayed sleep-wake phase disorder was the most common. And so what a delayed sleep-wake phase disorder is essentially when our clock is shifted later. So, maybe the average person's brain thinks bedtime is, let's say, 10:30 or 11 o'clock. Well, in this population, the brain might think bedtime is, 3 a.m. or 3:30. But then as a result, that same brain thinks that it's time to wake up around noon or, 1 in the afternoon. And this obviously causes great issues, particularly when we're forced to wake up early despite getting to bed very late. This is a very specific treatment that again we will talk about shortly. But one clue differentiating delayed sleep-wake phase disorder from, and it really is an important distinction, because I see a lot of patients who are thrown on all these sleeping pills with the belief that they have chronic insomnia disorder, and none of these sleeping pills works. And one clue is that most patients with chronic insomnia disorder, despite maybe taking hours to fall asleep at night, their brains still wake up early, 6 a.m., 7 a.m. And there's not an ability to go back to sleep. Whereas someone with a delayed sleep-wake phase disorder, if left to their own devices, meaning no alarm clock, no one waking them up, they'll sleep past noon. So that's one of several clues. A concussion doesn't cause shift work disorder. I see, you can see that I started there, but I just wanted to mention it because, I think shift work disorder is a bit of a spectrum. So I think everyone has a different ability to cope and adapt to shift work. And what I do see sometimes is people who do shift work and are kind of managing, and then an event happens, and it doesn't have to be a concussion, but a concussion is a great example of a medical event that just, I think, really sort of derails the ability to cope with that shift work. And it's just something to be aware of, because, return to work is sort of an important part of, rehabilitation for concussion. And sometimes important to be aware of how shift work, or even if shift work should be reintroduced. So moving on to the parasomnias, the two that I wanted to highlight, one is REM sleep behavior disorder, and the other is nightmare disorder. So when we're sleeping at night, our muscles are relaxed. And in fact, not just relaxed, they're paralyzed. And that is to prevent us from, dreaming that our house is on fire and then jumping out the window, or dreaming that we're being attacked by a mugger and then end up, fighting our bed partner. But unfortunately, sometimes the brain loses that ability to paralyze the muscles. And that's in fact what happens is dream enactment. And nightmare disorder is kind of self-explanatory, but I'll elaborate a little bit. So going back to REM sleep behavior disorder, so it's essentially dream enacting behavior. It can lead to injuries. That could be punching a wall, punching a lamp, punching a bed partner, could be jumping out of bed. And there is a bit of an association with PTSD, though exactly why these two are related is a bit unclear. But antidepressants are a very common cause of REM sleep behavior disorder. So it's just if dream enacting behavior does arise following a head injury, the first thing I wonder is whether an individual has been put on antidepressants. And nightmare disorder essentially just means recurring or frequent nightmares that's causing some kind of problem, either fright or distress, or daytime symptoms because of the disturbed sleep. And it can be seen in the context of PTSD or other psychiatric disorders. And there are medications that can cause nightmares. So beta blockers are a family of medications that are often used for post-traumatic headache that have migrainous features. So medications like propranolol or nadolol, and of course antidepressants can also cause nightmares in a less predictable way. In terms of the sleep-related movement disorders, the few that I think are worth mentioning, so restless leg syndrome and periodic limb movement disorder, they are two conditions that sit on the sit on a spectrum of the same pathophysiology. There's sleep-related bruxism, which I'll explain in a moment, and then a lot of these issues can be due to medications that we prescribe. So restless leg syndrome is essentially an urge to move or shake the legs. They're often worse. That feeling's often worse at rest, tends to be worse at night, and there is usually at least partially, if not total relief by movement, and that movement could be stretching or walking or shaking the legs. And I mention this because both antipsychotic medications and antidepressant medications can actually cause restless legs. There are more common causes, but if, again, sort of new onset of restless legs post-concussion, the first thing I wonder about is whether an individual has been started on a medication that might be causing those symptoms. Periodic limb movement disorder. Periodic limb movements in sleep are stereotyped leg kicks or jerks that occur during sleep that can disrupt sleep if they happen at a high enough frequency. And much like restless legs, they can be due to antidepressants and antipsychotics. Sleep-related bruxism, so that is repetitive teeth grinding or clenching during sleep. So that can cause, of course, damage to the teeth, but it can also cause headaches, jaw pain, and even neck pain. Sometimes identified by a bed partner who hears the noise, sometimes it's identified by a dentist, or sometimes by someone who's assessing pain in the head, neck, jaw area. And there are several risk factors, including severe TBI, anxiety, antipsychotics, antidepressants, and sleep apnea. So, I think like most things in medicine, an approach to a diagnosis starts with a history. That includes getting a feel for the sleep routine, that is the sleep schedule, a review of systems, and then sometimes we'll use questionnaires to facilitate information gathering. A physical exam can sometimes be informative, and there are several investigations that we have at our disposal. So a sleep diary is essentially just a sleep log. Actigraphy is technology that essentially uses an accelerometer to track movement, with the idea being the more still someone is, the more asleep someone is, which isn't exactly true, but it's a pretty decent surrogate. Polysomnography, or what's referred to as a level 1 sleep study, is the sleep study or sleep test that people are generally familiar with, where they go into a sleep laboratory and sleep overnight. There are level 3 sleep studies, so that's a home sleep apnea test, where an individual will wear the apparatus at home in their own bed, but this device really only tests for sleep apnea and does not evaluate for many of the other conditions that a formal polysomnogram would. However, in Ontario, unfortunately, the level 3 sleep study is not OHIP covered, and so most people opt for a more detailed polysomnogram, even when the question is that of sleep apnea. A multiple sleep latency test is a test that evaluates propensity to sleep, and a maintenance of wakefulness test is a test that helps us gauge the ability to maintain alertness during the day. So sleep history involves getting the sleep routine. So that is, what time someone goes into bed, what time they turn the lights off, how long it takes them to fall asleep, how often they're waking up through the night, what time they wake up for good, what time they get out of bed, and how often they're napping. A review of systems could be questions that, go down the sleep related breathing disorder route, asking about clenching or grinding, asking about daytime symptoms, about restless legs, nightmares, asking about any unwanted nighttime behaviors. This is the Epworth Sleepiness Scale Score. Again, just a questionnaire that is used to gauge daytime sleepiness. I see that it's already almost 6:30, so we're gonna skip a few slides. We're gonna skip that. I've talked a little bit about the tests already. I believe these slides are going to be made available to you, so you're welcome to take a look at this after. But I think we'll skip over this for interest of time. So when we talk about treatment, so treatment of insomnia as a symptom, you want to try to identify and treat any primary sleep disorders that might be causing insomnia, the symptom. So, when we talk about difficulty falling asleep, so, do they have restless legs? Do they have a circadian rhythm, sleep-wake disorder? When we talk about waking up frequently in the night, think about periodic movement disorder, sleep apnea, nightmare disorder. You want to address any psychological conditions that might be impacting sleep. You want to address any medical conditions that might be impacting sleep, and looking at someone's medications to make sure they're not taking something stimulating close to bedtime. So sometimes stimulants are used post-concussion, sometimes antidepressants, steroids not so much, but again, just looking at their medications, looking at one's medications to make sure they're not causing the problem. Sleep hygiene can be helpful to manage insomnia. I think most people are familiar with, I imagine most people on this in the audience today are familiar with sleep hygiene, so we're going to skip over that. But when we talk about the treatment of chronic insomnia disorder, so that again is the condition, the first line treatment unquestionably is cognitive behavioral therapy for insomnia. There are obvious issues with this, which include finding somebody who's trained in cognitive behavioral therapy for insomnia. This can be a costly endeavor. It can be a big time commitment for patients, and also there's a lot of homework that needs to be done, so it's an effort commitment as well. But there are many studies that have shown now that that cognitive behavioral therapy for insomnia is effective in the traumatic brain injury population. And in fact, there's even a study that's shown that this care being delivered virtually is effective. So cognitive behavioral therapy for insomnia, there's lots of different components. You can see they're on the slide. I've listed the components and the the issue that they're trying to address. Sleep hygiene is often wrapped into cognitive behavioral therapy, but sleep hygiene on its own is not effective for chronic insomnia disorder. But sleep hygiene, along with some of these other modalities, can be quite effective. I would love to talk about this more, but I think in the interest of time, we're going to move forward. So if chronic insomnia disorder does not respond to cognitive behavioral therapy for insomnia, or if cognitive behavioral therapy for insomnia is not available, then sometimes we will use medications. Melatonin is not something that's typically used for chronic insomnia disorder, but specifically in the TBI population, there is some evidence to support trying it. I would say that in my experience, the results are modest at best, but melatonin is generally safe. And so, but just to be aware, taking it at the wrong time or taking too much can actually worsen sleep. So if it is going to be tried, it should be used correctly. When we talk about medications, sometimes using a medication to treat another condition, but harnessing the side effect of sedation is reasonable. So for just as an example, if, headaches, post-traumatic headaches, a lot of times amitriptyline is used at night while it's sedating. So it's maybe a good choice for people who have trouble falling asleep. Or, medications like trazodone or mirtazapine in depression, again, harnessing the sedating side effects. There's a newer to Canada class of medications called the dual orexin receptor antagonists, which are really sleeping medications that seem to have a relatively good safety profile when we think about side effects that we would not want in concussion, meaning balance issues, driving issues, cognitive issues. So this may be an emerging medication in this population. Lots of different ways to treat sleep apnea, less ways to treat central sleep apnea. Less relevant to concussion, so we're going to skip over this. Sorry, everyone. So for REM sleep behavior disorder, obviously you want to remove any offending agents, and otherwise melatonin is first line. And for nightmare disorder, again, similarly, you want to address any underlying cause. Imagery rehearsal therapy provided by some psychologists and psychotherapists can be helpful, and prazosin, a medication, in my experience, is quite effective. For restless legs and periodic limb movement disorder, again, you want to remove any offending agents, rule out reversible causes like low iron or low B12, and dopamine agonists, medications such as pramipexole, or the alpha-2 delta ligands, medications such as pregabalin can be quite helpful. For sleep-related bruxism, mouth guards are very common and can be quite helpful. For people who are chewing through their mouth guard or damaging their teeth despite a mouth guard, or having significant pain despite a mouth guard, can sometimes benefit from receiving Botox injections into the masseters. Medications are probably not worth the side effects. So to conclude, almost on time, sleep disturbances and sleep disorders are common in the TBI population. Insomnia is incredibly common, and almost all sleep disorders are treatable, so they're important to recognize and address. So I think that's it. So we're only 5 minutes over, so I think we still will have lots of time for questions if there are any.
That is great. Thank you so much, Dr. Parekh. That was excellent. And so I would just ask if anyone has any questions to put those into the Q&A. Also, just to let you know, just as a reminder, the PDF of tonight's talk, there was a question about that. That has been posted in the chat. So just so you can go there if you want to access that. So we have a question from Colleen. How can you get a home sleep apnea test if you suspect maybe that you have it?
Yeah. So I'm going to give you the longer answer because I think it's important. So different provinces in Canada have different funding models. And so the problem is um, twofold here. So firstly, in Ontario, I presume all the audience members are from Ontario.
Not necessarily. We actually have people from all over the place. I think probably the majority of people are Ontario. So
Can we ask Colleen where Colleen is? Is Colleen in Ontario? Because I want to answer the question for the right
yeah,
province.
I can't tell. So Colleen would actually have to type it in. So Colleen, if you're there, you can type it into the Q&A and I'll be able to see if you're in Ontario or not.
Where does Colleen live? Give us your address. No, I'm just kidding.
No.
I'm just kidding.
Well, let's see if it's in the chat. I don't see it in the chat either.
Okay, so let's
Maybe just go over what for Ontario.
Okay, so yeah, so in Ontario.
Yes, Ontario, she said.
Oh, perfect. Oh, perfect. Okay, great. So in Ontario, in a level 1 sleep study, so that's the formal full polysomnogram that's done in a sleep laboratory. That test itself is covered by OHIP. So that test does not cost a patient any money. But a lot of people don't like going for such tests out of well, it could be for several reasons. Not wanting to sleep in an unfamiliar environment with strangers around. No one else is in the same room as you, but it looks a little, most of these labs look a little bit like a dorm or like a motel kind of setup. So some people don't like the sort of lack of privacy. Some people are worried they're not going to be able to fall asleep in an unfamiliar environment. So there's lots of reasons why someone might opt for a home sleep study. I think the two important points here, number one, a home sleep study or a home sleep apnea test really just assess for sleep apnea and nothing else. But if that is the question, then a home sleep test could probably answer that. Maybe not as accurately, but still could answer that. That would be something that you would likely need to pay out of pocket for. And usually where one would obtain a home sleep apnea test would be from the laboratory where these sleep studies are done. So they usually have, many labs have like a few devices on hand that they would then ask a patient to pay whatever that might be $100, and they would get the device to take home and wear. Now the problem is that if sleep apnea is identified, payers for the treatments of sleep apnea in Ontario might not recognize a home sleep apnea test as a sort of accepted diagnostic tool. So what may happen is you'll go for a home sleep apnea test positive, and then still have to go for an in-lab test to have that sort of formal diagnosis, so that the government through ADP or private insurance for them to actually then to help pay for the treatments, which are not typically covered by OHIP.
Okay, that's great. Thank you. Kathy asks, she said, you said there wasn't much to be done regarding central sleep apnea, but is there anything that you can recommend?
Oh, so, yeah. So I didn't mean to say that nothing can be done. I was kind of running out of time and getting a bit anxious about that. So, so first of all, if it's felt that the sleep apnea is from opioids, then of course the first step is to try to reduce the opioids. There are other medical conditions that can cause central sleep apnea: heart failure, kidney disease. So you might want to be evaluated for that to make sure there's not an underlying medical condition. In the absence of that, what is typically used first is what we refer to as PAP therapy. So something like CPAP is often tried first and often unsuccessful. Then usually something called BiPAP will be used with a little bit more success, though both CPAP and even BiPAP can actually worsen central sleep apnea. So it just needs to be done carefully, but certainly would be the next step. And then failing that, in the correct patient, something called auto servoventilation can be used. The problem with this type of device, it looks like a CPAP or BiPAP machine, but it is incredibly costly. and funding is limited. So it can be treated. I didn't mean to imply that. It's just the range of treatments are just more sort of limited. It's either, find the underlying reason and addressing that, and if that can't be done, then it's essentially a machine. Was sort of what I was getting at. But yes, it certainly should be addressed, and most sleep physicians would be comfortable managing that problem.
Great, thank you. Yeah, it looks like Kathy had added, I have had the level 1 sleep test. I have both an MTBI and sleep apnea that predated my TBI. So it sounds like maybe she's had multiple TBIs, I guess, and she uses a CPAP every night. Okay. We have another one. Had my pineal gland removed when I was 4 on sedations, I guess maybe sedatives for sleep. Any recommendations for other ways to fall asleep?
Yeah, so I guess what I would be okay, so we'll take I think this principle holds true, and I see this so often, I think it's worth saying one more time. So if you're saying you have trouble falling asleep, so you're saying that you have insomnia, the symptom, right? So I don't know, you can't, there's no treatment for a symptom, meaning, like, if I said, well, I have chest pain, how do you treat that? Well, it really depends on what's causing the chest pain, right? Like, if you went to your doctor, said, I'm having chest pain, they said, well, Tylenol should help. You'd say, well, that's crazy. Like, it's not going to help if I'm having a heart attack or if it's reflux. And so it's the same idea. So you have insomnia, but that insomnia is a symptom of an actual condition or disease. And so sure, in this case, it might be determined, which can be tricky, that yes, removal of your pineal gland and any sort of resultant loss in melatonin might be the reason why you're having trouble sleeping, in which case you might try melatonin if that's your hypothesis. But ultimately, there is usually an identifiable reason, or it's labeled as chronic insomnia disorder if really nothing is identifiable, and then we treat it as such. So I guess what I'm trying to say is, you're saying that you are having trouble sleeping, and I am saying I don't know what your diagnosis is. It may be related to having your pineal gland removed, but not necessarily, because insomnia as a symptom is super common, but having your pineal gland removed is so rare that you'd have to be careful to make that association. But if that association is made, trying melatonin is reasonable. If that association is not made or not so clear, then looking at what other reasons you might have for having trouble sleeping. And chronic insomnia disorder is so common. Often there's some kind of event where people can't sleep, and then just becomes this learned behavior. And so, cognitive behavioral therapy is always something worthwhile trying, even if you're not sure of the diagnosis, because the risk is, other than the cost, is really zero. You get to typically meet a really nice psychotherapist or psychologist, and usually you get something out of it, even if insomnia is not your problem.
Thank you. Samantha's asking, what causes nightmares and crazy dreams after a TBI? 4 years later, I'm still experiencing throughout the night.
Yeah. So as I mentioned in the talk, so I don't know obviously the details of what happened to you during the event or the injury, but it can be a part of PTSD, or it could be a consequence of medications you might be on as a result of the injury. But in the absence of that, I don't think any of us really have a good sense of the why. But as I mentioned, prazosin as a medication can be quite effective if it's just the nightmares in isolation. If there's not an underlying treatable reason. Sleep apnea actually can cause nightmares and vivid dreams as well. So I would want to make sure that you don't have sleep apnea. Often treating sleep apnea, the nightmares settle out, or the vivid dreams for that matter. And if the imagery rehearsal therapy is great if the dream content is this, if it's nightmares or at least distressing dreams and the dream content is the same every time, so you can work on kind of rescripting that, and so that the dream, you can almost have the dream sort of play out a little bit differently. But I don't think anyone really knows why, after a concussion or even just out of the blue, why nightmares arise in the absence of some of these identifiable secondary causes.
Great, thank you. The next question is about sleep studies, and I believe what they're asking is, if you're just going in for the sleep study, which is usually just one night, I believe, if somebody has too many issues, are they going to, I think what they're asking is, are they going to pick that up in one night? Like, is it possible that by just being there one night, they're going to miss something?
Right. Okay. So the first comment I'll make is that I think a sleep study is only useful for identifying a few things. Okay, I think there's very few things that a sleep study can actually tell us. The thing that it is most geared towards answering is there a sleep-related breathing disorder? So it can identify sleep apnea and can differentiate obstructive sleep apnea from central sleep apnea. I think that is the test that, I think that is the condition this test best assess for. The other condition this test can look for is this periodic limb movement disorder. If someone has severe obstructive sleep apnea, you can miss periodic limb movement disorder, but usually people who are diagnosed with sleep apnea are then retested with whatever treatment modality is used. So then if someone does have obstructive sleep apnea and periodic limb movement disorder, usually the second night where you're proving whatever treatment works for the sleep apnea, you will then see the periodic limb movements once the breathing is fixed. So yes, you could technically miss these periodic limb movements in sleep if the sleep apnea is really bad. And really, like, the only other I guess thing that the sleep study really evaluates for is the parasomnia. So people who have non-REM parasomnia, so things like, which we didn't really talk about, but like sleepwalking, sleep eating, or REM sleep behavior disorder, or nocturnal seizures. A sleep study is good at looking for that. But beyond that, I honestly don't think that a sleep test tells us much more than that. I think I answered the question, or at least I hope I answered the question.
Yeah, no, thank you. And actually, this next question is sort of a two-parter, but they're asking, what causes frequent wakenings throughout the night with difficulty falling back to sleep, and what can I do so that I get better sleep? I had a sleep study, but all they seemed to conclude was that I didn't have sleep apnea. Other than sleep hygiene, I received no other suggestions.
I'm sorry that you weren't helped. So if you don't have sleep apnea, again, if we're talking about the sleep test, the second question I would have, and the only other condition on the sleep test that would be identified as this periodic limb movement disorder. So I would go back to have a look at your sleep test to make sure that you don't have a high frequency of these periodic limb movements in sleep, which could be the reason why you're waking up so frequently. And if you're not aware of any other issue that's causing it, like nightmares or needing to go pee in the night frequently, or pain or shortness of breath when you're laying flat, if none of these things are present, then you probably have chronic insomnia disorder. I'm not diagnosing you, just to be clear. I don't have all the facts, but in this kind of scenario, one would imagine that this is ultimately chronic insomnia disorder, in which case I would say cognitive behavioral therapy for insomnia is the first line treatment for chronic insomnia disorder. But I don't know what you have. I don't have enough information, but just generally that would be my comment.
Mm-hmm. Yeah, I guess it's complicated because there's so many different things too, just outside of like sleep disorders, but even things like, eating too much before you go to bed. I was listening to a podcast and they were commenting on that and how that can disrupt our sleep. So I guess the sleep hygiene includes a lot of different areas. So, and actually that was the other part of their question. They say, I live in Toronto. How can I find a CBT insomnia specialist?
I am not I'm not aware of like a database um and that one can like go online to seek a certain professional. Um, but it's been my experience, and maybe Leslie, you know better, but I would say that in my experience, well, there's two things. Firstly, most like larger clinics that are like full of psychologists and psychotherapists will typically have a provider who's experienced or and trained in CBTI. So one option might be to just reach out to some of these larger, multi-provider clinics to see if there are providers within that clinic that have that training. Your primary healthcare provider may be able to direct you. But certainly, like if you have a sleeping issue that you feel deserves, um, investing time and money into CBTI, then I would usually by that point you would have seen a sleep doctor, and um, they could certainly direct you. I don't know that this is the appropriate forum to give specific names of people I use. I don't want to do that, but you may have already seen a sleep doctor, and that doctor can direct you. Certainly, the people that I refer to offer even virtual. So regardless of where in the province you are, you can still get that care, provided you have high-speed internet and all the other things that one might need to be able to pursue that.
Yeah, and the Ontario Psychological Association has on their website, they have a find a psychologist sort of function where you can go in, you can specify, if you're wanting to do in person, the location, the gender of the person that you want to see, and also like the area of difficulty. So I'm assuming you could probably go in there and indicate sleep issues, and then it would, and then it would come up with a list of individuals that you could look. So that would be another option.
That's great.
Robert is asking, is there a safe dose of melatonin? And then he says Benadryl, and how long is it going to be safe? Should the melatonin be obtained by supplements counter, I guess over the counter, or pharmacist? Sorry, I'm not exactly sure.
I'm going to try to answer the question.
Okay.
Firstly, and I made a comment, and I actually regretted not speaking to it more, but so melatonin is often used, I would say, like in general, like largely inappropriately. There's really only a few scenarios where it should be used. It's appropriate to use in REM sleep behavior disorder. It's very appropriate to use in circadian rhythm disorders. If you have either of those conditions, you should be under the care of a sleep physician, undoubtedly. If you have chronic insomnia disorder, there's some evidence supporting trying it. If you're going to try melatonin, you want to take it at a time that replicates when your brain would normally start to regulate melatonin. So I usually advise patients in general to take melatonin 2 hours before they go to bed, to keep a consistent bedtime, and then to consistently take melatonin 2 hours before that bedtime. And the other comment I would make is to not take too much melatonin. So usually I recommend somewhere between 1 and 3 milligrams. And as you probably know, it's often sold as a 5 milligram and a 10 milligram. But the trouble is, if you look at the way the body produces melatonin, and in the rationale for using melatonin in the concussion population or the head injury population is that there was at least one study suggesting that people post TBI, their brains make less melatonin. So that's the sort of rationale, though there are a couple of other studies suggesting that it actually may work. The rationale is that we're not making enough melatonin. And so you want to, in my mind, kind of supplement or replicate what your brain should be doing. So you would want to take melatonin 2 hours before bed, because that's when we start to upregulate. And you wouldn't want to take too much, because normally what happens is we start to produce melatonin, but if our melatonin levels are high after our core body temperature reaches its nadir in the middle of the night, then we actually can push our circadian rhythm the other way, and it can actually make it harder to fall asleep. And so you want to make sure that you're not taking so much that you have a lot in your system that late into the night. So I usually recommend like 1 to 3 milligrams.
Great. Thank you. All right. Someone is asking about what you think about meditation for sleep problems after concussion.
Yeah, I mean, so, as I'm not an expert on this topic. I mean, I guess what I would say is that, relaxation techniques are part of, CBTI. So I think that, some of the principles hold with meditation. I'm not an expert on meditation. But I mean, I think meditation has lots of benefits even beyond sleep. So certainly trying it. There are providers who do guide or provide guided meditation for sleep. So I'm sure there is some evidence behind it, and I'm sure there's some benefit. But I don't think I can speak to it as educated as I wish I could.
Thank you. Is there anything that can be done to increase sleep duration? I used to sleep 8 hours a night, but now since the MTBI, the concussion, I can't sleep much more than 4 hours at a time.
Yeah. So again, again, I think I'm saying this a lot, but it really is important. So, again, you're describing insomnia, right? So in your case, not difficulty falling asleep, but difficulty staying asleep. And so the first step is to determine why you might be waking up prematurely. So as an example, you could have sleep apnea. So things that wake you up, so if you think about it, right, if there's something, let's say it wasn't even in like an internal medical issue, but if I came and woke you up like 5 hours after sleeping, it's not unbelievable that you would have trouble falling back asleep because you essentially just took a 5-hour nap, right? So getting back to sleep can be hard the later into the night or the closer to the morning that you get. So I guess the first step would be to make sure there isn't something there that's waking you up. That could be light coming into your room through your curtains, or noise from your, I don't know, kids or bed partner, or traffic on the street. If it's not something external, is it something internal, right? So could you have sleep apnea or periodic limb movement disorder? Or you're waking up to pee, or you're waking up because of a nightmare. If all these things are absent, which would obviously require some investigations, then some of the principles of cognitive behavioral therapy would be helpful in terms of looking at ways of helping you reinitiate sleep. It may not, if you're only waking up once after like 4 or 5 hours, the sort of staying asleep piece is not so bad. It'd be really kind of treated as like almost like a sleep initiation problem, right? Sort of reteaching you how to get back to sleep. So CBTI would be something worthwhile trying in that case. You want to make sure that you don't have, once in a while, a circadian rhythm disorder the other way. So rather than a delayed sleep phase wakes, you would have an advanced. And so in these individuals, people start feeling sleepy by like 7, 8, and then want to go to bed early, but don't because they want to watch Netflix with their partner, or read or do whatever needs to, or housework or whatever needs to get done. So then the people stay up later, but their brains still say it's time to wake up really early in the morning. So just something also to think about, or to have someone maybe think about for you.
Great, thank you. Okay, I know we're almost at time, but I'll maybe squeeze in another 1 or 2 questions. We have a question. Is there an app, this is a good one, for CBTI that someone could try before they, start seeing someone in the interim?
I don't know the answer to that.
Okay, I only know this because I was looking the other day for a client, and I haven't actually tried any of them, but there are actually several CBTI apps that are out there. Some are free, some are paid, and I don't have it. There's actually, if you Google it, I found an article that was sort of like the best, CBTI apps for 2023. So you can definitely find those out there. I can't, endorse any of them. Haven't checked any of them out, but they're definitely out there. So it's for sure something that you could just try out for free. And let's do one more. What might shortness of breath while lying flat indicate?
Right. So I guess, if someone tells me they are having trouble breathing at night while they're awake, so different than sleep apnea where there's trouble breathing while asleep. So, first of all, there's some conditions that are just worse at night. So as an example, like asthma can be worse at night. So I guess I would want to know, is the shortness of breath a time of the day issue, or is it a position of the body issue? If it's a time of the day issue, then again, asthma worse at night. What a shortness of breath when laying flat, it's called orthopnea, and orthopnea has a few different causes. So the two that I most, and maybe it's an exhaustive list, but the two that I think about most, one is heart failure. Not to frighten you, I'm not saying that you have heart failure. I'm just in general terms, that would be one thing I would worry about. And the other is that some people can have weakness of their diaphragm. And so what happens is, in order for us to breathe, our diaphragm goes up and down. And when we're laying down and gravity kind of shifts our abdominal contents sort of more towards the head, the diaphragm has a harder time kind of pushing down to expand the lungs. And so people who have a weaker diaphragm, which can happen for a variety of reasons, can also experience orthopnea.
Great, thank you. Do you mind if I ask you one more? There's just so many here. Yannick is asking about shift work disorder, because I think this is something that so many people struggle with. Says, I definitely have a delayed sleep-wake cycle. Are there CBT specialists that address this specifically? I think I've tried everything else for general sleep disturbances, melatonin, sleep hygiene, diet, etc. Do you know?
Right. So I think I'm a little bit confused by the question. So I thought I heard delayed sleep phase, but then I also heard shift work disorder, which are two different circadian rhythm sleep wake disorders. So if we're talking about so we're clearly talking about circadian sleep wake disorders. So if we're talking about delayed sleep wake phase disorder, then which is the clock thinks everything shifted later. So one has a tendency of falling asleep at like 2, 3, 4 in the morning, and then sleeping, if left to our own devices, till 2 in the afternoon. Then one approach to fix that. So this should be, at this point, there should be a sleep physician involved, clearly. But one approach is using melatonin and light therapy, where we slowly move the time back to a normal time by like 15-minute increments every month, using light and melatonin. The other way is what's referred to as chronotherapy, where we rapidly move you around the clock all the way around, but not quite all the way around, stopping short so that you end up where you should be. Both are best done under the care of a sleep physician. Shift work disorder, maybe a harder one to cover in like 30 seconds, but yes, there's a role for melatonin. There's often a role for light therapy. There's sometimes a role for stimulant medications, unfortunately. They're just sometimes needed. Sometimes there's other techniques like wearing sunglasses, simple things like wearing sunglasses when you're leaving work in the morning to reduce the amount of sunlight that you're getting on your way home from work, so that you have an easier time getting to sleep when you get home, using melatonin to help you get to sleep when you get home, using stimulants while you're at work if you're not getting enough sleep while you're at home, using light at the right times to help you get to sleep when you need to get to sleep, or stay awake when you need to be awake. But again, this also probably benefit from being under the care of a sleep physician.
Sounds complex. Well, thank you so much. Sorry for keeping everyone over time. I am just, before I say anything more, I just want to highlight that Christian has put an updated flyer for our fall series into the chat. If you're not able to get to that, don't worry. There will be reminders that come out to you if you are in attendance. Just also to let you know, as always, there'll be a very short survey that comes out, and we really welcome your feedback. I'm sorry I couldn't get to everyone's question. If you want, when you fill out your survey, you do have the opportunity to you know, if there's anything that didn't get answered, you can always type it in there, and as long as you provide us with an email to contact you, we'll try and get back to you to do that. So this is actually our last session for the spring series. We're going to take a bit of a break, and we'll be resuming in September, on September 12th. And as I said, the flyer is, thank you, Christian, has just posted there, and there will be emails that come out as a reminder, and it will run similar to as it has. So thank you again, Dr. Parekh. Really enjoyed your talk, and thanks for your time. And I hope everybody has a great summer. Take care.